okay with the material, is that correct? We did have a guest speaker. Jessica Salt is looking for volunteers for the student AT program, and so I'll be posting slides with information on that. She's looking for resumes and letters of intent by next Monday, so I'll post that when she sends it to me. Today's lecture, if there's no questions about the asynchronous components, we're going to be talking about the peripheral nervous system. And can anyone tell me what the peripheral nervous system would include, or how would you define that in terms of the neurological system? Exactly. So we're going to be talking about the basically spinal nerves and everything out. And so this, you have to understand or remember, the spinal nerves exit the vertebral column and then they recombine at the plexi to create our peripheral nerves. Does everyone understand what that means? No, so the plexi are going to be like your brachial plexus, your cervical plexus, your lumbar plexus, like that. So the plexi are the adding up of the anterior rami of different nerve roots to recombine into the peripheral nerves, yeah. So for evaluating the peripheral nervous system, when the spinal nerves are exiting, so here we see, this is where we would have our dorsal root ganglion, there's the ventral root. They're recombining to create a spinal nerve. This is where the vertebra would be, and then the spinal nerve exits. Once the spinal nerve exits the vertebral column, it divides up into two rami, anterior and posterior rami. So if you look at it right here, you can see the larger anterior rami and then the smaller posterior rami. The anterior rami innervates the skeletons, the muscles, and cutaneous areas of the anterior and lateral trunk and limbs. The posterior rami, which is smaller, innervates the paravertebral muscles and then the cutaneous area of the back. So when we are looking at our plexi, it is the reconnection and sort of like dividing up of the anterior rami. So clinically, you have to understand that the spinal nerves are mixed. So once we have the ventral root and the dorsal root recombine to create at the spinal nerve, the peripheral nerves are going to include both motor and sensory components. Joseph has a question. The posterior just does the spine and skin, not the latissimus. No, what is the innervation of the latissimus then, Joseph? You remember? Nope. Specific nerve. Nope. So if you nope. I think most people call it the thoracodorsal. Have you done the innervation in anatomy yet? So you have specific peripheral nerves that are associated with each of our muscles. And so it's important to note which peripheral nerves innervate which muscles, because then if we have issues with the specific muscles, then we can understand potentially what nerve that's coming from. And this is what the point of this slide is that remember that peripheral nerves are mixed. So we're going to have both sensory and motor issues. So that would include paresis or paralysis, or weakness or inability to use a muscle, sensory loss, abnormal sensations. When the muscle is denervated, we get muscle atrophy. And then we would also lose our reflexes because the connection with the spinal cord would be lost. And what you want to do is when you have sort of any of these signs clinically, you want to understand if they present in a dermatomal or peripheral nerve distribution. So if we look at this slide here, it's important for you all to understand the difference between a dermatomal distribution versus a peripheral nerve distribution. So Joseph was asking about the innervation of the latissimus dorsi. That's a good question in that each of the muscles are going to be associated with a specific peripheral nerve, and you can see them all here. Right? You can understand the big ones: ulnar nerve, median nerve, radial nerve. The peripheral nerves are recombinations of the spinal nerves, specifically the anterior rami. So the peripheral nerves will have components from, for example, let's say the brachial nerve or the median nerve. It'll have components from spinal nerves C5 all the way to T1. So it'll include branches from all of those spinal nerve levels. When you look at how the spinal nerves, or sorry, how the peripheral nerves are distributed differently, then looking at it from just what areas would one spinal nerve innervate cutaneously. So do we all see that there's a difference between a dermatomal distribution versus a peripheral nerve distribution? Each of the spinal nerves recombine to create our peripheral nerves. But the way that the way that they're distributed is that all of the branches from each of the spinal nerves will end up being in this distribution, touching the skin using different peripheral nerves, using these peripheral nerves. So clinically, if you can understand where the abnormal sensations or the clinical presentation of those neurological symptoms are, you get a better idea if it is a spinal nerve lesion or a peripheral nerve lesion. Does that make sense, everyone? Peripheral plexi innervates dermatomal rami, or nope, look at it this way. One second. Boom. So here we have the brachial plexus. Okay? Here we have our spinal nerves. Okay? This will C5 to T1. See how the anterior rami are coming out? So saying ventral rami, the spinal nerves. They come out and then they recombine to end up creating all of these peripheral nerves. So then here, thoracodorsal, this is the innervation of the latissimus dorsi. It's going to have contributions from all, well, you map it out. So it's going to have contributions from all of them. It makes sense for the body to be this way, because if, let's say, we only had C5 innervates, biceps and pec. If you have an injury there, then you're going to lose function of that muscle. Here, we would still have function of the muscle. If we lose one spinal nerve, there's still contributions from other levels. Yes, that's correct, Joseph. So do we all understand the difference between peripheral nerves versus spinal nerves? The spinal nerves come out and then recombine like this to create the peripheral nerves. Here we have the lumbar plexus. Sacral plexus is the sciatic nerve, look how big it is. And up here we have our cervical plexus. So let's talk about the peripheral nerve anatomy then. Now, just like we were talking about the neurological system and the connective tissue layers, like the dura mater and the arachnoid space, remember that? The connective tissue is continuous through the whole neurological system, and it's continuous with, therefore, the peripheral nerves. There's 3 layers of connective tissue in our peripheral nerves. There's the endoneurium, which is closest to the middle, the inside, perineurium, and epineurium. The perineurium surrounds fascicles, just like there was muscle fascicles, or groups together within the nerve. And then epineurium is like the duramater that would sort of encapsulate the entire nerve. And now the connective tissue is important because it is there to hold everything together and offer support. And think of our neurons, or sorry, our nerves. When we move, our nerves are getting stretched. So we need the connective tissue layer there to take the tension, or else the tension would go onto the axons. And we know that they work through those channels. So if they're getting pulled, the channels that are integral for function are going to get pulled open and not function properly. So here we have a cross section of a peripheral nerve. So we can see individual axons. So we would have our endoneurium in between. So that's going to separate all the individual axons. That's going to contain the myelin. Then we have our perineurium that is surrounding fascicles or bundles. And then we would have our epineurium all around, holding it all together. Here we have blood vessels, the arterial branches that would provide blood supply to the nerves. Remember that our peripheral nerves are mixed, so they're going to have sensory, motor, and autonomic components, okay? So when we have injuries to peripheral nerves, we're going to have symptomology in each of those symptoms, potentially. We've just talked about this, but these are the main plexi. You're not going to have to, you may have to, I don't think there's any questions about there is no questions about the peripheral nerves associated with each of the different plexi. I think there's just one question on plexi itself. So you don't need to label any of these diagrams, but they're there to demonstrate how the neurological system is put together. And so we've reiterated that today, and I think it worked. That's sort of helping you understand how peripheral nerves are created or combined and then go off into the rest of the body. Does that make sense, everyone? Or do we have any more questions? Yes, comma. Double yes, comma. Is that like a Gen Z thing? Yes, comma, meaning yes if you have questions. Okay, I'm just kidding. I spelled sense wrong. Sorry, buddy. Okay, so remember that the peripheral nerves, remember the neurons themselves utilize the most energy, so they need a high blood supply. And so there's arterial branches in the peripheral nerves for that reason. What's really important for the health of the nerve is that movement. So they stretch continuously with movement. And it's important because that movement helps optimize the health of the nerve by promoting blood flow and the movement of metabolites. It helps break up any scar tissue or inflammation that's been building up. And in a lot of cases, think of peripheral nerve lesions. Clinically, we do a lot of nerve flossing exercises. It's to sort of break up the adhesions in the nerve and promote proper flow. Because remember, the function of the nerve is dependent on neurotransmitters getting built at the cell body and getting sent all the way down through anterograde movement all the way to the axon terminals. If we were to look at the epineurium and endoneurium under a microscope, you can see how it's wrinkled at length. What do you think that would be? Yeah, exactly. So it can stretch, right? We want the neuron, or sorry, the nerve to be stretched or stretchable. So that way all the tensions from movement, right? The nerve tension tests and just the tension associated with moving our limbs, it puts the tension through the connective tissue, not the axons. And then what's the listening? So one last point is that remember all or none response of our neurons in terms of the motor system travels from the lower motor neuron and includes the motor unit or the muscle fibers associated with that lower motor neuron. So if we have an issue with activating those muscle fibers, it could be because of the muscle, but it could be because of the lower motor neuron not transmitting that signal. Okay? So, oh.
Will the car be waiting for us in Boston? Yeah, a limo will be right on the tarmac.
Someone's watching Netflix. I'm not sure what they're watching. Sounds like Bridgerton. So, now let's talk about clinically what presents when you have a peripheral nerve lesion or dysfunction or injury to a peripheral nerve. Remember, because the peripheral nerves are mixed, we can have sensory, motor, and autonomic issues. However, the symptomology will present in a peripheral nerve distribution. So if it's the median nerve, it's going to present in a distribution of where that median nerve goes, not where dermatomes go. Does that make sense? So let's first talk about the sensory changes that are associated with a peripheral nerve lesion. So it's going to affect all of our potential sensory senses. So that would include what? Fine touch, proprioception, vibration, pain, temperature, and crude touch. Clinically, there's different terms associated with different types of symptomology. Hyperalgesia means increased sensitivity to pain. Dysesthesia means abnormal sensation. Paresthesia is the clinical term for numbness or tingling. And allodynia is when you have normal stimuli perceived as painful. Now, this clinically also presents in central sensitization, which is like chronic pain. So what you would do is you would so let's say you put pressure on the right arm, it's at the right arm that hurts, put pressure on the right arm, pressure on the left arm, same pressure, but it hurts on the one side. Yeah, so it is subjective, yeah. Abnormal sensation would be like, sometimes you get a burning sensation, some people get really descriptive with their clinical presentation. I feel like there's fluid moving down. I get a lot. I feel like some burning, itchiness. Like think of the gamut of different things that you could have weird sensations. When your body, what will cause that is abnormal connection. So if the sensory processes aren't coming up properly, your body interprets it as static. Just like when the HDMI cable is broken, it's static on your TV, right? The computer that's sort of putting together that electrical information to make a picture, it's filling in the holes. Same thing with the neurological system. No, nausea is more systemic. This would be, remember, would be over a peripheral nerve distribution. So they would have, let's say, I have a burning sensation of these 3 fingers. That's indicative of carpal tunnel syndrome, which is a pinch of the peripheral nerve right here. Fibromyalgia is increased sensitivity, but globally, because it's not because of a peripheral nerve, right? All of a sudden now with fibromyalgia, it's not a peripheral nerve distribution. It's a whole body distribution. So that indicates it's not a peripheral nerve lesion. The take-home point with all of these clinical changes is that if they present in a peripheral nerve lesion, or sorry, a peripheral nerve distribution, then we know that it's a peripheral nerve. What about motor changes? If we have problems with the motor system, so we've got lower motor neurons, we're not going to have proper activation of motor units associated with that lower motor neuron. If we have weakness, that's called paresis. If we have complete muscle loss of like function loss, that's called paralysis. If a muscle completely gets denervated, there will be no activation of the lower motor neurons. If we have a pinching of the peripheral nerve, so denervation means the nerve is cut. If we have a pinching of the peripheral nerve, only some of the axons are going to get pinched and not function properly. So we'll have some motor units firing and some not. So that's going to lead to weakness. If we have complete cut of the nerve, that means none of the lower motor neurons can fire, and then we have paralysis. Involuntary contractions happen because of this right here, fibrillations. So because if we have denervation, there's no descending command. There's no release of acetylcholine receptors. So the muscle is going to upregulate acetylcholine receptors, and with an increase in the number of receptors, sometimes they're going to be floating acetylcholine around the body, and it'll react and cause these involuntary small twitches, like little twitches, very small. Autonomic changes is the ones that don't get, yeah, exactly. So probably from other nerves that aren't innervated, they'll float around a little bit. But because the body wants to work in homeostasis, right? So if it's not getting, if there's no acetylcholine being released, the muscle is going to upregulate acetylcholine receptors to see if that's the issue, like automatically. So it's more prone to picking up those like floating around acetylcholine neurotransmitters. Yeah. Just like when we were talking about schizophrenia and the whole dopamine and your body like regulating the difference. Yeah. So autonomic system is not one that we've talked a lot about in this course, but it is our regulatory system. And so we'll see autonomic changes if there is damage to our peripheral nerves as well, because that's how they run. If we have damage to a single peripheral nerve, it is usually when it is significant. So if it's just a single nerve, autonomic, because it is full body, autonomic changes will occur if it is completely severed. And what we would see would be a loss of like sweating or sympathetic control of the smooth muscle fibers in that area. And we couldn't get edema. If we have autonomic changes in a group of peripheral nerves, something like that would cause systemic changes or more global changes like a polyneuropathy or diabetes, we will see problems with regulating blood pressure, heart rate, sweating, what else, bladder function, more systemic stuff. Does that make sense, everyone? So autonomic dysfunction will include our homeostasis type presentation. There's a term. Are we okay to continue? No questions? Joseph, Classy? Oh, she said it makes sense. Perfect. Okay. Trophic changes is a clinical term to describe the combination of symptoms that a patient would present with a complete denervation of a particular nerve. So how can that happen? A laceration or a crushing injury? Trophic changes will present with muscle atrophy, edema of the limb, so the skin will become like shiny and brittle. I'll show you pictures. Because of the loss of autonomic function, there's going to be a loss of blood flow, so pooling, and loss of blood flow will lead to poor healing of wounds and infections, ulceration of the cutaneous and subcutaneous tissues, as well as neurogenic damage, because with the loss of sensation, the patient won't feel the grinding of the bones or pain. And so there's just like compression injuries. So trophic changes happen when there is an interruption of the nerve supply. So clinically, it's called trophic changes. I think I have some pictures. Yeah, here we go. So see how right here, brittleness of the skin, ulcers, see a limb edema. This is a big ulcer here. This is most likely diabetic patients. This one, not yet. When it is when it gets black, that's when they consider amputation. One second. So the problem with these areas is a lack of blood flow. And so if there is a lack of blood flow to a specific area, so see how it's cut off here? This one looks like it was damaged just to one peripheral nerve. Here it's the whole foot, and here it's definitely the whole limb. And so the reason why this would happen, specifically in diabetes, is if you think of diabetes, what is diabetes clinically? Okay, and so that's right, Hannah. And diabetics don't have insulin to take sugar out from the blood. And so what you get is you get a lot of sugar in the blood. They have a high blood sugar. The molecule, if you were to look under a microscope, the molecule of sugar, the carbohydrate, it's sharp. So glucose is a very, very sharp molecule. And so if there is more sugar in the blood, when you have the small blood vessels, the arterioles at the end of the distal limbs, that molecule cuts the insides of all of the little blood vessels. And so you get a loss of blood flow to the whole limb. So to Joseph's question, you would get a loss of blood flow to a whole distal limb area. And when you have a loss of blood flow, then you get a loss of the neurons first, right? Then if you get loss of sensation, diabetics don't realize that they've cut their foot because they can't feel it. And typically if it's older individuals, the self-care is maybe not there. And so those injuries, because of lack of blood flow, won't heal, they'll get infected, and the people may not even know they're there. So this is causing neuropathy. But that group of symptoms is called trophic changes. Yes, that's why I have one right here. You want to see her? This is what she does. So we get diabetics sent down all the time. And ulcers smell. No, this is not a mononeuropathy. This would be a polyneuropathy. A mononeuropathy would be like a nerve impingement syndrome, like sciatica or carpal tunnel syndrome or compartment syndrome in your leg, or yeah. No, poly means multiple nerves, yeah. So here we go. So the classification of neuropathies is going to be based on the number of nerves that it's affecting. So a mononeuropathy would involve just a single nerve. So if we're looking at the foot, that's multiple nerves, right, Joseph? Multiple mononeuropathies are when you have multiple single nerves in one area. And then polyneuropathy is when it is a whole bunch of nerves systemically or in a big area. And this typically presents with those trophic changes that we saw on the previous slide. The most common would be diabetes. And we'll talk about other ones that are common as well. But let's first talk about mononeuropathies. So for Joseph and for everyone, yeah, so hand and stocking is polyneuropathy because it's the distal limbs. So you would get, usually it's as a result of something like systemic or toxic, right? So with genetic disorders where you get a buildup of abnormal proteins, with diabetes, you get a buildup of sugar in the blood. It collects most distally because there's the lowest blood flow and the smallest blood vessels. But let's talk about mononeuropathies now. Mononeuropathies are when you have one peripheral nerve injured. Now, these are typical of our neuropathies that people are presenting with, like nerve compression issues. They're graded on severity, and they're ranked from traumatic myelopathy, or affecting just the myelin, traumatic axonopathy, or enough to affect the axons, and then the last one, severance, is when the nerve is cut. Traumatic myelopathy typically happens as a result of repetitive trauma to the neuron or to the nerve. So like compression syndromes, it is compression, repeated compression and inflammation, irritation. Clinically, they're referred to as the nerve entrapment syndromes, things that we've all probably dealt with. Has anyone ever heard of carpal tunnel or thoracic outlet syndrome or piriformis syndrome or peroneal compartment syndrome? So those are all traumatic myelopathies. The nerve is still intact. It's not cut. It's the myelin. With the repeated inflammation, the myelin starts to degenerate. So myelin is important to get that action potential to fire quickly and accurately. If the myelin is gone, then you get a signal slowing down, and it's a problem with the flow of that signal. And so when we have problems with myelopathies, we're going to have the most effect to the largest myelinated axons. So which one were those? Of the size of the neurons, I know Joseph knows, yeah. So we're going to get the problems with those. So we're going to get motor issues, discriminative touch, right? Proprioception, this was the most, discriminative touch, motor, and then obviously our reflexes. We're also going to have sensory issues. But here is how that injury progresses, where you get focal compression, or repetitive stretch, or trauma. There's a buildup of scar tissue in that area or inflammation. It's because of the way that the neuron is, once there's inflammation, it's going to spread and then hit the epineurium. And then that's going to, it's like swelling and it compresses in on itself. And then we know like scabs on our skin are thick. It's the same thing on the inside. It causes a hardening of that part of the neuron. And then you have a lack of movement, then you have a lack of exoplasmic flow, and then the neuron just continues to degenerate. Here we have a common peripheral neuropathy or nerve entrapment syndrome, carpal tunnel. That is compression of the median nerve, and it's usually from typing, right? Because of the repeated pressure causes inflammation right here. Then that would cause swelling, restricted flow of the nerve, and then you get clinical presentation here. So this is a peripheral nerve distribution. This is where the median nerve goes. And so you would get a lack of sensation, you would weakness in this area. And if you look at this gentleman's hands in the diagram, what do you notice about the meat of the thumb, the thenar eminence? So that is atrophy. Yeah. Because of the compression, there's a problem with the motor signals getting sent out. This is a very serious case. Usually doesn't present like that. I feel like carpal tunnel syndrome is the most overly diagnosed disorder, when a lot of times it's not even carpal tunnel syndrome. Sabrina, no, you are going to not get that. Yeah. So with tradesmen, it's because like a thing like your grandpa and like being an electrician, like he's probably having his hands in like weird positions, and think of already the compression plus now moving the fingers, it is irritating like friction, swelling, boom. This is a stain from myelin, so you can see how you would have a traumatic myelopathy here. Myelin's gone. So treatment is making sure that you take pressure off of the nerve. So take the pressure off of the nerve, and so there's different treatments to do that. Try to break up. So has anyone ever worked in like a rehab clinic? So there's ultrasound, there's acupuncture to decrease the muscles and generate blood flow, stretches, massage, and then to get more blood flow and to spur the nerve to heal, exercising. That's what all physical therapists do. So an occupational therapist is return to work and return to daily life. So actually occupational therapists don't do, well, some of them do clinical stuff, but it's more about what are your barriers to get back to what you need to do. So that's why they work a lot in hospitals with like neurological patients returning back to daily life. So occupational therapists would come in after the acute rehab. So physios, chiros would do the more acute stuff. Traumatic axonopathy is the next sort of intensity of injury. It is when there's enough trauma that the axons are affected. Now, typically this happens when you have dislocations or like fractures where the bone gets split apart and then pulled back together, right? Like it breaks, but gets pulled back together. That force of it coming back, if there's a nerve passing through there, will get crushed. Has anyone ever dislocated or broken something significant? And what is the first thing that they do? They check to see if your nerves are working, because that'll let them know if there was a crush injury. So when you dislocated your shoulder, did they test your hand to see if it was still working? If you had any numbness or tingling? Yeah, that's why. Because then they know that there's a nerve pinch, so they gotta like, that's a big deal. They gotta like re-dislocate, pull the nerve out. They gotta, yeah. So when there is a significant enough injury to break down the axons, the healing process is a lot different. So if we're thinking about a nerve, right? If the axons are crushed or broken, they don't just like heal and recombine. Everything, all the axons have to die distally and regrow from the proximal end. That's called Wallerian degeneration. So you get degeneration of the axon distal to the lesion, and then the proximal axon regrows down the connective tissue along the same path and reconnects. It grows at about a distance of 1 millimeter a day. It does happen on its own, but it's a very, very slow process. So if you have a nerve injury that has axonopathy, it's a very long rehab process. You can improve the growing of that nerve by trying to use it. So that's why you try to like activate that area. It sort of stimulates more regrowth or quicker regrowth. Severance is when you have the neuron physically torn or cut. So you can have it torn. People falling out of a tree, they'll try to grab on the branch and then it pulls and it's enough to break the brachial plexus. Stab wounds, or has anyone like ever? When I was in undergrad in res, someone punched the window and they, you know how it has like the metal in it. So when he punched through, the glass stayed, and when he tried to pull his arm out, it cut all like the neurons, all the nerves. And so when that happens, you know what happens, eh? So if the peripheral nerve is lacerated, the surgeon has to go in with little microsutures and grow back the connective tissue that we had talked about in the other slides. You can't reattach axons. You gotta try to line up the nerve the way that it was, sew it, and pray that it's in the right alignment, that when the Wallerian degeneration happens, it's gonna follow along the same path. Yes. Because it would be, think about how painful it is when you have a peripheral nerve lesion, like a myelinopathy. And that's only affecting the myelin. Now we're, yeah. Yeah, so then, yeah, so if you pinch a nerve or like, you know, you hit your funny bone, think about how much that hurts. It would be infinitely more painful than that. Multiple mononeuropathy is now when we have multiple single nerve lesions at once. And so typically, this happens as a result of a loss of blood flow to a specific region. So in the hypothetical chance that with diabetes, it would cause inflammation of just, or the breakdown of just one blood vessel going to some nerves, that could be a multiple mononeuropathy. It can usually happen with, does anyone have heard of vasculitis? When you get an infection that becomes an infection of a blood vessel, so it swells and then you get a loss of blood flow to one area. So that would be a loss of blood flow to one specific area. We know that the neurons, or the nerves take and use the most energy. So it's going to be the nerves that are affected first. And so we get a multiple mononeuropathy. Polyneuropathy is the glove and stocking distribution. And this is when we have many nerves affected. We talked about diabetes, but other causes can be toxic, metabolic, or autoimmune. Okay? Now, if you think about when toxins or with autoimmune disorders, you get a buildup of those antibodies, right? When there's ever a buildup of something in the blood, it's going, what about like, has anyone ever heard of, oh my God, gout? Anytime something builds up in the blood, it's going to get deposited in the feet and then the hands, because that's the furthest away from our heart, right? With the lowest blood flow. So it's going to get pushed down, stuck in the small vessels. And that's why with this, you get a buildup in the hands and the feet in a glove and stocking distribution. Does that make sense, everyone? So when you have a diabetic polyneuropathy, you have all that sugar in the blood that's going to affect blood flow to the hands and feet, specifically the feet first, and then you get all of this like sort of ulceration. Does that make sense, everyone? Why is everyone doing the yes comma thing? Is that a thing? Justin? I'm gonna start doing it now. It'll be our inside joke. Ooh, I like it. I'm gonna change the final just to have, instead of periods, I'm gonna have just commas. Don't put this on the test, comma. Here we have another example of a polyneuropathy because we've talked about diabetes. Charcot-Marie-Tooth. Has anyone ever heard of CMT? It's one of the most, I think I have 3 patients right now. Not that I'm healing their CMT, but I'm dealing with the side issues. It's one of the most common inherited polyneuropathies. And so what it is it is a problem in one of the alleles. They can't break down a specific protein. And so you get a buildup of abnormal proteins. And then it causes degeneration of the axons and myelin wherever it builds up, typically the hands and the feet. So these patients, you can watch the video, but they present with like a claw foot. It's really, really shocking to see almost. It's characterized by muscle atrophy in the lower legs and feet, and they have this high arch with claw toes, so like this. Yeah, this one's genetic. So it leads to a buildup of proteins. The buildup of the proteins causes degeneration specifically of the nerves. And this is it on an X-ray finding. Yeah, but except that's stuck like that. The reason why they do this is because they get significant loss quickly of their nerves and their feet, and so they can't feel it. And so if you can't feel your foot, the way to walk and make it stable is to mash it up like this. We used to call it in radiology class, when people present with like a bag of bones that are just mashed up, it's usually CMT, because what they do is there's no pain. So they walk like your foot, I don't know if you can see, like the foot, like can you see? Like they're walking on their foot, they're jamming it, so that way it's stable because they're just like rubbing on all the bones. They can't feel pain, but over time, quickly, the bones are all just going to break down. And that's why they present like this. Does that make sense? So that's another example of a polyneuropathy. Does that make sense, everyone? Cool. So the last area that can be affected in a peripheral nerve lesion is, remember that the peripheral nerve and the muscle fibers that is associated with the lower motor neuron, that is one unit. And so you can have dysfunctions of the neuromuscular junction. We've all talked about myasthenia gravis a couple times. So that is, remember, the loss of acetylcholine receptors. So that could be a result that can present in clinic. And then botulism is can happen when ingesting like food with the botulism bacteria in it, and then the toxin it generates is affecting the acetylcholine receptors. Has anyone ever had Botox? Botox means botulism toxin, and so they use it therapeutically and cosmetically to stop the firing of muscles because it's going to interfere with acetylcholine at the synaptic terminal. So you don't get acetylcholine being released. So that would be just motor though. So botulism, Botox they don't use for pain. Oh, has anyone had Botox injections? Because I would agree with Joseph that it is obvious. It looks worse. Because then it's like this. Like, I don't have any wrinkles. I look so beautiful. Therapeutically, I've seen Botox used a lot for like muscle spasms or people with dystonias or like that kind of sense. Yeah. Okay, yeah. So there you go. And then, so Sherry, did you get Botox to sort of decrease the spasm? People get Botox for headaches in their head. I've seen that a lot. Okay. Did it work, Sherry? Okay. Yeah. Yeah. So that's how I've seen it. Yeah. So Sherry, did you have a nerve conduction velocity test? Has anyone ever had a nerve conduction velocity test? Has anyone ever heard of it? So a nerve conduction test is when you test the integrity of your different nerves. No, that is no, that is like a thermogram, not really evidence-based. Not a lot of chiros use it much anymore. I don't think. But a nerve conduction velocity test is when they take two needles and they put it in a peripheral nerve. So they'll test a bunch of peripheral nerves, right? You get a nerve conduction velocity test when you present to the doctor. They think that yes, there's all these indicative signs of a peripheral nerve lesion. Let's send it out for a test to see how bad it is. What they do is they'll go through all the peripheral nerves in that area, and they put one needle at one area, and then approximately one needle at the distal end, and then they'll shoot a signal and see what the signal is on the output. Myelopathies would show a decreased conduction speed or velocity. Axonopathies would show a decrease in signal amplitude. Now, why would that be? If you have a loss of myelin, what's going to happen to our action potential? Right. So then if you get a nerve conduction test and it shows that the speed of the signal is slower for that. So what they'll do is there is a chart of how fast the nerve should be. If the nerve is slower, there is a myelinopathy happening. What would happen if there's an axonopathy? So some of the axons are gone. Well, so with axonopathies, because it's not all the axons, it'll be just some, potentially. Yeah, so it'd be the amplitude, right? Because now all of a sudden, so let's say there's 10 fibers, there's only 5. So now the electrical amplitude is going to be just the 5. So it would be smaller. So here we have decreased velocity, decreased amplitude. If there's no signal, then it was a significant axonopathy or there's severance. Any questions? I want to finish off just talking about sort of some clinical things as people present with neurological symptoms. You want to evaluate the neurological presentation with a thorough history, get an idea of how it happened, if it was a long onset, if there was any mechanism of injury. I'll give you an idea of potentially what could have happened. Then you would go into your clinical physical of the integrity of the nerve, you would evaluate peripheral versus dermatomal distribution. Impaired progress. So if people present with, so this is for diabetes specifically, if you're thinking that the nerves are getting really affected, clinically, if you have all of these, then it's time to get a nerve conduction test and to consider intervention. If someone presents with a neuropathy in the foot, they'll have a decreased ankle reflex, decreased vibration sense, so that's your dorsal column, and decreased proprioception. So this is like a med school OSCE prep. So if you guys want to look at it your own time, they're going through how to do a neurological test, I think, of the hands. But there was a question Arvin asked, how do you treat a peripheral neuropathy? So someone's coming in with a myelopathy. Now remember, it's as a result of repeated friction or trauma to an area on the peripheral nerve. And so conservative treatment is usually with helping the muscle tightness and the inflammation of the area through different modalities to help take the pressure off the nerve so it can start to heal, and then promoting improved movement and sort of, blood flow to the area through exercises and using of the nerve. Other things pharmacologically, like anti-inflammatories, are used. Gabapentin is a neurotransmitter blocker for like neural symptoms. They used to do a lot of carpal tunnel release, would be an example. So you can, or with compartment syndrome, sometimes, has anyone ever had compartment syndromes in their shins? Where they cut the fascia to allow for more space to take the pressure off the nerve. With polyneuropathies, remember it's multiple nerves, so it's not a sense of healing is going to be occurring with pressure off the nerve. It's a whole bunch, right? So of nerves, sorry. So, and it's typically, like in the diabetes case, it's just a systemic thing. So with diabetes patients, I remember like our chiropodist or podiatrist is always talking to the patients. It's talking about or promoting proper care for their feet. So, you should always take your socks off, look at your foot, wash any wounds, and always be like, it's a more of like a routine that you have to do with the elderly. Any questions? So at the end of the lecture, these are just showing the different main peripheral nerves of the body. So you won't be tested on this, but they're just, again, showing you a diagram. I took them from the textbook of the distribution. So you would go through and like, oh, okay, well, here we go, the musculocutaneous nerve. If it's around this region, okay, it's peripheral nerve distribution. Here we have the median nerve. It's the ulnar nerve. Oh, that is all of them down the side of the cerebral nerve right there. That's the axillary nerve. It's the lower leg. Any questions, anyone? Okay, perfect. Well, that was the second last lecture of this course. Next lecture, we're going to be talking about the spinal cord. Are we going to discuss that? Did you see Jess's little thing at the beginning? I'm going to post her slides. I'm sure she's emailed me. I can hear my email going off. So I'll just post those. I don't know much about it. It's not through me, but she asked me if she could talk to the class because I said you guys were all really great. Okay, yeah. So go through the slides. Yeah. It's fun. And it's good. It's a good experience. It's just long hours, right? So you have to get up early in the morning and stuff, and so that might not be for all of you. But I'm going to let you in on a little life secret here. Most jobs, you got to be up early in the morning. Oh, yeah. Hey, Joseph, change it. You're going to be an all time of the day person. Hashtag hard work. Success professionally isn't about your academics. It's more about your drive and your ability to work hard. Straight up. Quotes apostrophe. Or comma. Okay, awesome. Well, if there's nothing else, hope you all have a good day. Go finish your assignment. Bye, everyone.